All right, everyone. I'm honestly extremely excited about this one. Welcome to Healthcare Unfiltered. I've been looking forward all Sunday for this episode that we will air actually around ASH 2021, where everybody thinking hematology. So we always strategically air these episodes to make sure we get the highest viewership and listenership. So thanks for tuning into Healthcare Unfiltered. I have three amazing guests today. We're going to talk about broad topics, clinical trials, real world evidence. How do we criticize clinical trials without being criticized ourselves? And then we are going to use a clinical trial that was published in Lancet recently as a platform for this conversation. We can summarize in a little bit. Okay, so we have three amazing colleagues and phenomenal lymphoma and cancer specialists. We start with Liz, you go first, introduce yourself, where you are, and then we go to Alan Skarbnik, and then we're to Papa, Aaron.
All right, I'm Liz Brem. I'm currently at UC Irvine, and it's still weird for me to say that. I think I've been here for like 5 years, and I still feel like I'm new to California, being a East Coast girl originally, and I'm super excited to be here.
Thank you. And Liz, you do all malignant hematology or specific lymphoma or?
So my clinic is majority lymphoma. There is some multiple myeloma, and I still, as one of the relatively junior people who is heme boarded, still sometimes hold down the fort with some of the benign hematology. On the inpatient side, it's everything. So I'm just finishing up 2 weeks on the inpatient service. So I'm pretending to treat leukemia and all kinds of stuff.
Excellent. Scarbs, your returning guest, appreciate that. As you introduce yourself, please tell us how many years before we opened that restaurant.
I cannot, 8 more years, I guess. I cannot escape you, apparently. Thanks for inviting me again. I'm Alan Skarbnik. I practice in Charlotte. I'm the director of the Lymphoma and CLL program and of the immune effector cell program at Novant Health Cancer Institute in North Carolina. Happy to be here. It's a pleasure to talk to you and to Liz and Aaron. It's going to be fun.
Great, Alan. Prior episodes when you were on have had amazing downloads and viewership. So, I'm inviting you because I have secondary motive. I'm all about the light.
You have COI. I got it.
Papa.
Hey. First, it's good to be on with 3 people I consider friends, and hopefully we all get together soon. I'm at UCSD. I do bone marrow transplant. We do everything. I don't do benign heme anymore. Maybe a week I volunteer and do the consult service, but lymphoma, leukemia, myeloma, you name it, we do it.
And Aaron, when I visited with you at UCSD and I taped me invading your office, that video had about close to 7,000 views. So I should probably come back to UCSD and see if I can top that. Okay.
Yeah.
So let's start with clinical trials versus real world evidence. Liz, I feel a lot in the media, real world evidence gets a huge bad rap where, we're not living in the unreal world. Real world evidence is not controlled. It's difficult to interpret, whatever. I mean, all of these things. What's your view on real world evidence?
Well, I think all those criticisms are fair, right? But at the same time, there's a lot of questions you can't answer for whatever reason it is in a randomized clinical trial, whether that is, it's just too difficult to study, whether that's, honestly, sometimes it's that people hold biases that are so strong, you can't actually do the trial. I think one area that comes to mind when we think about this is the infamous question of, that I know Aaron has opinions on this, the infamous question of CNS prophylaxis and DLBCL, right? So we have all of these retrospectives, some of which are very well done, have tons of patients. And I don't think anybody would ever let us do a randomized trial, nor do I even know how we would begin to do that. So sure, yeah, it's not perfect, but sometimes it's what we've got.
I mean, Aaron, you hate real world evidence, right?
Yes. Sorry, someone was. Yeah, I don't hate real world evidence. I've just been in my career. I've just again been burned by real world evidence, and you can kind of, the more I see real world evidence in retrospective studies that I've done myself, you can kind of just get what you want out of it, get the answer you best want. I do recognize that some questions we will not ever be able to answer, but, for the various, things where I'm super critical about, I do think randomized trials can be done. And I don't hold much for real world evidence other than, okay, that's possible. And maybe we should study it further.
Alan, where do you stand on real world evidence?
Okay, I think, well, I think real world evidence is important in a number of ways. It definitely does not supplant a randomized clinical trial. Obviously, if you're trying to look for a more definitive answer, a randomized clinical trial is the gold standard at this point. However, there are a number of things, as Liz pointed out, that cannot be teased out of a clinical trial, or questions that are not asked in a clinical trial even, that may be informed by real world evidence. And not only that, populations in randomized clinical trials are highly selected. So these are patients who have very good performance status, very low levels of comorbidities, perfect kidney function, EF is, and not necessarily they translate to what are the patients that are in front of you, right? And then you see a drug that's approved and you say, well, I want to use in my patient, but my patient didn't read the clinical trial and he doesn't fit that profile. So am I doing the right thing for the patient or not? I mean, for that particular scenario, that question has not necessarily been answered within the clinical trial, particularly when it's about toxicities, right? Not only efficacy, but toxicity, tolerability of the drug. And, with you and I, Chadi, we co-authored a number of retrospective data sets led by Anthony Mado in CLL that were very informational in the setting. I mean, when we had two new drugs approved, Videla and ibrutinib for CLL, there was data showing that if you use ibrutinib first, it seems that the PFS is prolonged. This was prospectively corroborated in the ASCEND trial, for instance, comparing a BTKI versus a PI3 kinase inhibitor. So, it's something that was informed years before by real world evidence. We showed that, for instance, the rates of discontinuation of ibrutinib in the real world due to adverse events were much higher than the rates of discontinuation in the clinical trials, that the PFS that we're seeing in the real world this didn't really reflect necessarily what the clinical trial showed, because these patients have more comorbidities, they discontinue the drug more often. So these are things that are in addition to information from clinical trial. And when a clinical trial is not available for a particular question, CNS prophylaxis case in point here, or other diseases that are more rare, or other instances where there's more rare, that informs your decision of how to treat the patient. Now, we cannot say definitely this is the best way to do it or this is the worst way to do it, but at least it's informational to some extent. And, there are good data sets, there are bad data sets, there are good ways to do it, there are bad ways to do it. Even the FDA, and I know Aaron's opinion was recently published on synthetic arms, I think that's something up for debate, but retrospective real world data sets that inform synthetic arms with the objective of minimizing number of accrued patients in clinical trials or decreasing costs and things like that. Obviously not a perfect world, but I think the more we deal with proper data collection, AI, integration of data collection with EMRs, some of the obstacles that exist in trusting the data and trusting how the data is collected may be to some extent supplanted. But having said all that, this does not replace a randomized clinical trial at all. I think we all agree with that.
So Aaron, what do you think if I tell you, I'm going to throw something at you that you might think is provocative? I think while you can never replace randomized controlled trials, I think randomized controlled trials are the biggest biased approach to answering questions I've ever seen in my life. It is taking patients that are young, mainly Caucasians, lack comorbidities, have excellent psychosocial support, They're able to drive and go to where the clinical trial exists. They are able to withstand frequent blood draws and biopsies if needed, and then to get the output and the results and then apply it to 90% of the population that does not get enrolled in clinical trials. How much more bias can we go through?
It's not perfect. It's better than real world evidence. I mean, the bottom line is the real world evidence can't control. There is just something about it when you're seeing the patient in front of you, taking into account as a physician, all these different variables, no matter how much we control for everything, including, when you're just, the doctor decision that you decide to escalate therapy or not based off your gut, you just can't account for that on retrospective real world stuff. And that's why that again and again, and I'm specifically talking about with therapy real world evidence, not for other stuff that you can do real world data on, but it's specifically for escalating therapy, which is a lot of it where I have problems with, whether it's high risk for myeloma or EPOC for lymphoma. You just can't account for that in any sort of analysis that you do. The transplant literature is riddled with this. By the fact that you're taking them to transplant, you're selecting great people. Even if you try to account for that, you're not, because they're going to get the transplant while the ones who didn't get transplant for whatever reason. So, the randomized trials aren't perfect, but it's still the best that we got in this current situation. Maybe we can make randomized trials better. That's beyond my pay grade. But we could maybe do randomized trials more in sick, frail patients, more like the real world, but in a randomized setting that gets rid of all co-founders. Also, my baby's awake, so I apologize.
No, it's okay. That's maybe your baby's way to fame, because that's really how it works. But it's okay. Don't worry about it. We would love to have the baby on the show. Liz, I mean, we still don't enroll a lot of patients in trials. Tell listeners the latest stats you know of in terms of enrollment on trials and so forth in the US.
Well, it's really funny that you mentioned it now. I was actually, like, right before we started this, I was catching up on my ASH poster, and one of my presentations this year is about my study in patients 75 and older with DLBCL, right? So a population that is not frequently studied, and really in the US has never been studied. There's been one randomized trial in the UK, but never been studied in the US. And so, just in kind of reviewing that data, I mean, when you look at certainly the older patients, they account for less than 10% of patients enrolled in NCI clinical trials. So particularly in our older patients, we're doing a dismal, terrible job. And that is one patient population in general. I think there are limitations to the randomized data because those patients just aren't included outside of trials where you're specifically selecting that population, which we're starting to do with some encouragement and handholding from our geriatric colleagues, but we really haven't done a great job to date. And I actually don't know the nationwide data. I know we always talk, like, when you're at a comprehensive cancer center, right? It's the magic number is to be 10%, right? 10% of people coming through your door are supposed to be on a clinical trial. And I mean, I have to imagine that outside of the big NCI cooperative trials, it's got to be easily less than 5%, right?
Way less than that.
Yeah.
Right.
I think,
it's probably around 1%.
Yeah.
Alan? I would absolutely believe that.
Yeah, I mean, for you to have like COC accreditation, you need 6%, I believe, of your analytical cases enrolled in a clinical trial. That needs to be prospective, need to sign consent for. So, retrospective analysis.
But Alan, am I crazy to think that clinical trials are I genuinely believe that randomized controlled trials are extremely biased. Like,
yes,
I'm not saying we can replace them, but I mean, it is the most biased approach.
Yes, it's biased. Not a question. I think everything that we do has bias. Everything that we do has conflicts of interest. We try to minimize those, right, as much as we can. I mean, there are methods to try and minimize inclusion bias, selection bias, etc., in a prospective clinical trial. However, to your point, and it's pretty much what I was saying before, the population in the trial doesn't reflect the real world population, right? Not only do they need to be healthy, they need to have economic health, right? Because it requires them coming for more visits, coming for more tests, coming for more blood work, more imaging that not necessarily is covered by the clinical trial itself. Lots of times this is charged to patient insurance or the patient itself because it's considered standard of care. So, you know, in general, patients are going to end up spending more money to participate in a clinical trial if all those costs are not properly covered, particularly in phase 3 trials, especially if an arm is standard of care, because, you know, they'll be receiving the standard of care and paying more for that. You know, so that, yes, you have an economic bias, you have an inclusion bias, you have a number of biases in the study, but I mean, how to fix that, right? I think particularly in the United States, trials that run in the United States in comparison to European countries, where you have universal health care and access is different, and, you know, they have nationwide PIs where, you know, all hospitals enroll patients in the clinical trial, and you have different abilities that we do have here. I think it makes a difference, but particularly in the United States, yes, there's absolutely bias. I mean, we include population that's not what we end up seeing on a daily basis.
And certainly, Aaron, you've been critical of clinical trials. I mean, I think, you know, so I see that you, you know, not all trials, I mean, to your earlier point, that trials are not perfect, but it is, you know, sometimes the best that we have. What are we going to do? And you have voiced some criticisms to some of the clinical trials and so on. And I think one of the things that you oftentimes, the counter argument that gets told to you, and I've seen on social media, because I want to really bring that to light, is that, well, you have not really ran a prospective clinical trial from inception to completion, so how dare you criticize our clinical trial? Right, Aaron? I mean,
how dare I comment on a clinical trial? You know, how dare I watch a movie and say it sucked because I didn't direct it? Like, how dare I? Or critique a chef because I don't know how to cook because I thought the food was bad. Listen, I'm not criticizing like complexities. You know, I think I'm criticizing fairly straightforward things that any non-clinician or anyone who's not in medicine or science would agree with me upon. I'm pretty basic things, you know, giving control arms therapeutics that we know are inferior to what we would give in our same exact clinic to the next patient off trial. I don't think there's anything wrong with doing that. I don't think you need to have designed a multi-center randomized trial to critique that, you know. So yeah, I mean, do clinicians that don't run trials not have valid, you know, input to help design trials? Do we not have any insight into this? And by the way, I do like help run some studies. It's not like I'm a complete foreigner to this. So I don't get that argument. I don't buy it one bit, and it actually angers me quite a bit. On social media, I never hear that, at least my lovely group in UCSD. I mean, we are all very open, and I don't get that criticism ever in person, just on social media.
Liz, have you seen that on social media or elsewhere where people say, well, not until you run a clinical trial from inception to completion and write it up, your arguments are not valid? What's your opinion?
I actually haven't seen that, and maybe I've just been like blissfully unaware, and if so, good for me. But it actually really surprises me to hear this criticism, because I mean, since medical school, right? We were all doing journal club. We were always taught how to read papers, how to evaluate a study. And because, you know, it's a key skill in medicine, whether you're writing a clinical trial or not. And, you know, when I think of, for example, our community colleagues, right? They're very valuable members of the team. Many of them enroll lots of patients on clinical trials, whether they're intergroup or industry. And their input is incredibly valuable because you need to make sure these studies are going to be feasible in their setting. And so I'm a little disheartened to hear that this is a thing, because I actually feel like it's a really important skill that we all need to have. And especially just sort of thinking that really clinical trials should be teamwork, whether it's, you know, treating investigator, your statistician, whoever. And so it just sort of seems like I can sort of agree with Aaron on this one. Like, I'm okay. I can't compose a thing, but it's okay for me to not like a song. You know, it's not okay. You know, and I think hearing Aaron speak, you know, sort of the things that come to mind are like, you know, things like use of chlorambucil, for example, as a control arm in CLL. Like, come on, guys. I don't need to have finished enrolling to a clinical trial for that to be a fair criticism.
Scarbs,
I agree with everyone. I think it's a completely invalid argument. I mean, it's a logical fallacy. It's ad hominem at like the pure definition of it, right? I mean, you're attacking the credentials of the interlocutor. Anyone can criticize a clinical trial. It doesn't even need to be a doctor. Patient advocates, they're very well educated, can read a clinical trial and say, hey, I don't think this is good for us, or this or that, or anyone. I mean, anyone. You don't need to be a physician. You can be a nurse. You can be a statistician. As Liz was pointing out, everyone's entitled to an opinion if you read and rationally criticize that. I think that's fair game for everyone, and saying the argument you haven't run a clinical trial is it's absurd. I mean, no one should use that argument to criticize.
But we've seen
or give a counterpoint, and I've seen that happening. I think the issues with social media in particular are, number one, any kind of discussion from whomever it comes and whoever it goes to needs to be civil. I think that, criticizing studies is one thing. Criticizing the authors is a very different thing. I think, when the level starts going to becomes personal, I think that kind of detracts from the argument on both ends, very, very, very much so. And on top of that, I think that there's a number of people who made careers of being clinical trial critics, right? And, and then it bags, it's like, what's that all about, right? I mean, who watches The Watchmen, right? I mean, I think that's kind of the question there. It's like, someone is criticizing a clinical trial, well, then that person needs to be open to criticism of their criticism to the clinical trial as well, right? And
you can criticize me all you want, just don't criticize me that I don't run trials, so I can't criticize.
I'm not criticizing you, Aaron. Yeah. I didn't say that.
Yeah, I know, but I mean,
I'm not. I'm just making a point.
No, but I think others have criticized Aaron because they said he hasn't ran trials. I guess the question that comes to mind listening to Alan, are we able to separate the trial from the authors though? Aren't the authors responsible for the trial? Like if you're criticizing the trial, isn't that by default you're criticizing the authors who put their name on the trial?
I don't think necessarily, no. I mean, you're criticizing a trial, criticize the design of the trial, criticize the inclusion-exclusion criteria of the trial, the conclusions of the trial, how the stats were run. You can criticize the aspects of the trial. When you criticize ethics of the authors who ran the trial, that's a problem, right? Not only because people weren't there, they don't know what the discussion, how happened with the patient or not happened, but also leads, especially when it's in an open forum, it does leads to mistrust and distrust in physicians from patients, because patients are watching all of these discussions too. I mean, we talk a lot amongst ourselves on Twitter and social media. You have your podcast on. Don't think that patients are not watching this or not reading this, and then may say, hey, you know what? I was part of this trial. Like, what's that all about? Should I call my doctor? I think that...
yeah, they should.
Well,
I mean, if I create a medical error, like I tell my patients, or should we not hide it from them?
It's like, look, come on. I mean, I think that's the thing. Like, how criticize the study. Don't say.
I criticize studies. The authors are connected to the studies. I mean, if a study is unethical, I mean, should we just then be hush about these things, or it will continue to happen?
No one said hush about this thing.
But we can't talk about them on Twitter?
Of course we can talk about it.
Well, you just said we shouldn't do that.
No. That's not what I said. I said there are forms to do it, Aaron.
So is Twitter a form?
What's unethical? Okay, let's use the Van Epoch phase 1 study that you criticize very openly there.
Okay, and so before we criticize, Yeah, no, but before you use that, because this will be a
By the way,
platform.
Alan, I love you, and I'm not angry here. This is just discussion.
No,
You know,
We're friends. I know.
No,
It's all good.
everyone, we are friends.
If I had emojis, I will have hearts all over. But I want to, before we talk about that trial as a platform, as an example, because it was very highly publicized on social media. Liz, do you want to take on the opportunity to summarize the trial, and then I have Alan and Aaron get into what happened after that?
Oh, I want to double check. I know what we're talking about, the Venn epoch for double hit lymphomas.
No, not the ASH one.
Yeah,
no, phase one published on Lancet that included standard DLBCL.
Yeah, this one, the dose-adjusted epoch-R plus venetoclax, which was published in Lancet Heme, I believe, right? Or Lancet Oncology, I forgot.
Lancet, I believe it was Lancet Heme.
Or one or the other.
Yeah, I wouldn't. Yeah.
So I just want to make sure we summarize it in 1 minute or so, and then I want to get Aaron and Alan to get into it. So Liz, you want to do that?
Well, I got to tell you, I thought we were talking about the Alliance trial, so I was caught off guard a little bit here. I was not prepared.
Okay, well, it's the I think it is an interview.
We can summarize. It's a phase one study. Yeah, it's a phase one study. There it is. Do you want to go for it, Liz? Or
I'm pulling up the paper as we talk. All right. So we're looking at Venn plus dose-adjusted epoch, single-arm, phase 1, ages 18 to 80 with histologically confirmed previously untreated DLBCL. So basically all comers, adult DLBCL, regardless of cell of origin, double hit, or anything like that.
Correct.
Okay.
Liz, how many had non-double hit lymphoma enrolled in the study over the total patients? I think that's.
Hang on. Hang on. Let me pull up the.
I believe it was 8 patients, Aaron.
Oh, I thought it was 12 or 13, but maybe I'm wrong.
I will tell you that
it's about a third of the patients. Let's put it like that. About a third of the patients.
Anyway, we're going to talk about this, but it's we keep doing these studies. And it's and look, I'm running an R-CHOP plus something study right now, so maybe I should put the shovel down, but there is some element of knowing, not selecting out higher risk populations, although I guess it's a phase 1, so maybe that's how you could justify kind of doing all comers.
When was that phase 1 started, Liz? When did they start enrolling? I can just tell you if you want.
Please do.
I believe they started enrolling in 2017.
That is correct.
Yes, and the CalGB, what is it? The 5. Someone tell me the number. Lymphoma doc. Yeah, that resulted at ASH. When 2016.
It was presented.
I believe similar authors were on both papers, so I don't want to feel that they didn't know the data.
Yeah. All right. So just at the breakdown, if you look at the table 1, we've got 50% or 15 patients with double hit lymphoma, 30% DLBCL NOS, 2 patients with primary mediastinal lymphoma. I don't know what I guess this is high grade B cell lymphoma NOS, whatever that is, versus previous categories, and transformed indolent NHL was only 2 patients or 7%. So about half of the patients were double hit lymphoma. Everyone else was a smattering of other histologies.
Yeah, one third was straight up DLBCL.
What's your beef with the trial, Aaron Goodman? Papa, what's wrong with the trial?
Yeah, so so this is a phase 1 study in newly diagnosed DLBCL, including double hit. It was enriched for double hit. So this is the whole population is a curable population. We're doing a phase 1, so proceed with caution at that point. They have 1/3 of the de novo DLBCL. For those who don't treat a lot of lymphoma, roughly 70%, if not higher, will be cured. Some of those had a low, what we call risk index in the disease.
So how much will be cured, you said?
What?
How much will be cured of that population?
Well, 70%. I feel like that's not.
That's a stretch.
It depends on which data set you're looking at.
Okay,
right?
So tell me how many will be cured.
Just correct me.
I think 60 is probably more accurate.
60% is probably more accurate. But
Papa Heme was off 10%. Okay, so they took these patients that were curative, and at the time of study enrollment, we already had the results of a prior randomized study that showed that dose-adjusted epoch-R in run-of-the-mill DLBCL was no better than R-CHOP. The curves literally trace each other. And it also showed that dose-adjusted epoch-R was more toxic, including neuropathy, febrile neutropenia, mucositis. Okay, so we know we have a regimen that's no better, but more toxic. And then we enrolled patients in that study with that.
All-comer, but be clear, that's all-comers DLBCL, right? So one of the
all comers.
criticisms of that
no
study.
problems with the double hit, all comers. We then enrolled patients on the study after that study resulted with DLBCL and treated them with dose-adjusted EPOCH-R plus an additional agent. So we know without the study that this is only going to be more toxic. I don't need that study. And we already know that this regimen is more toxic than R-CHOP in a curable population with R-CHOP. That's leaving out the fact that this regimen requires, in some places, hospitalizations, 5 days of coming and getting the therapy, as opposed to R-CHOP, which is fairly straightforward. And we know that R-CHOP in a healthy trial population has a fairly reasonable safety profile and can be safely done. Okay, so that is my beef with the study. We're signing up patients with curative lymphoma, giving them what we already know is a more toxic regimen, and then further toxifying it. And we are not even going to answer in the study whether this is beneficial. It's a phase 1. All we are doing is finding out the dose of venetoclax that we can combine with EPOCH. So basically, if you're signing up for this study, you should tell the patients, I am giving you a more toxic regimen. I'm then going to make it more toxic. And I'm not going to even answer for you in this study whether this is better. Thank you for volunteering. That's also the bottom line for those patients.
I'll also argue that actually the preclinical data for throwing in venetoclax is not great. It's a great drug in CLL, which is exquisitely BCL2 dependent. It's a great drug in mantle cell lymphoma, which is exquisitely BCL2 dependent, but there's not that clear dependence on BCL2 and DLBCLs. And even in double hit lymphomas, even though you'd say, oh, BCL2 is rearranged, venetoclax should work, but follicular lymphoma is a BCL2 rearrangement too, and it doesn't work in follicular lymphoma. So there's not only the EPOCH piece, but from the get-go, I've always actually been skeptical of the activity of venetoclax and DLBCL. Liz, end of statement.
Do you agree with me with my beef with the study?
Yes, I will agree with you with your beef of the study that basically selecting all comers with DLBCL and giving them EPOCH, given what we knew at the time, may not have been the best choice.
Well, but was it right for these patients to be enrolled? Yeah. That's my question.
Well, here's the thing. So, Alan, I think for double hit lymphoma, you correct me if I'm wrong. I feel the study is reasonable in the subset of double hit.
For double hits, I think it's reasonable.
I guess where Aaron is coming from, once you include the regular DLBCL, that's where he has struggled with that.
Yeah, that's my understanding. That's your beef, right? Like the run-of-the-mill DLBCL being included in the study.
Yeah, I have a pretty big beef with it.
Understood. Do we know, though, the run-of-the-mill DLBCLs, the breakdown? Like, for example, when this study was started, and even today, there's still some. So there's even today, there's still people who would give their dual expressor lymphomas dose-adjusted EPOCH. So it may be that these run-of-the-mill DLBCLs are dual expressors. And so based on the data at the time, this wouldn't have been completely So 40% of patients had MYC and BCL2 overexpression. The majority had some kind of overexpression. So I guess that would be my only kind of devil's advocate here is if most of these people were double hit or double expressor, then particularly given what we knew at the time, maybe it wasn't totally inappropriate.
No. I'm with you.
I'm not talking about double hit. Eliminate the double hit.
We're talking about the DLBCL that's not considered double hit, and that could be double expressor, or it can have, I don't know, a Ki67 of 99%, or may have a high IPI, or may have all of the above, right? So here's the thing, in my view. You cannot equate the findings of 50303 with the goal of the study. You're not studying EPOCH in this patient. You're studying a new regimen, okay, that has EPOCH within it, but you're studying a new regimen here, okay? So, if I was consenting a patient to the study, here's what I would say. I would say, you have a disease that we can cure about 60% of the time with our CHOP, 40% of the time, this is not cured, either doesn't respond fully, or it comes back down the road. Salvaging those 40% may be tricky, it may be complicated, etc. We know that not all the DLBCL is created equal. There are DLBCL that have a more aggressive course for one reason or another. There's DLBCL that are a little more indolent, to respond very well to chemotherapy. We're doing this study with a regimen that has been shown to be more toxic than R-CHOP. but not less effective, okay? And we believe that by adding this new drug to it, there may be a benefit. We don't know. That's why we're doing the study. It's very likely that this combination is going to be more toxic, and that's what we're trying to find out.
100% more likely going to be more toxic.
Sure, this combination will be more toxic. Even you can say that, okay? But, you know, I don't know who the patients who were enrolled. I didn't see the patient in front of me to say it was wrong or right to enroll those patients in the study, right? These may have been patients who would have come to me in clinic back in 2017 when we knew less than we know today. And I have said, well, with what I know today, with what I have in mind, I mean, it was presented at ASH, but still not published fully. That was 2 years after that.
Dude, there are authors on the same study. Okay, fine. I don't want to hear that.
Well, but not everyone. Okay, not every other thing all of the people. Anyway, that's not the point here. Here, hindsight is 2020, Aaron. I think the thing is that you don't know. I don't know. You don't know. You didn't see the patient in front of you that you enrolled the patient in that study.
We keep on making these excuses. If this was an isolated incident, I would give you the benefit of the doubt.
Aaron, please let me finish. Okay. I think there are two separate things here. One is, if we look at the design of the trial, should the design of this trial have excluded non-double hit? Probably yes. Okay. But probably yes. Looking at it today, knowing what we know today, and with some information that we had back at the time, yes, probably a better trial design would have been excluding the patients who don't have double hit. Now, is it wrong to include the patients who had diffuse large B-cell lymphoma? That's a different discussion. One thing is this perhaps not the best design. The other thing is this wrong, right? And that's where I think the debate lies in. We all agree with you that very likely that the trial would be best if it didn't include those patients. We will have better information out of it for a question that's a little bit more important at this point, which is how do we treat double hit, which we argued extensively a couple of months ago. I don't want to go down the rabbit hole again. But, you know, that's fine. It doesn't answer that question. It wouldn't answer anyway because of phase one. It will be informative, hypothesis generating. Will give you a signal to run a different trial, which it did. And unfortunately, that trial had excess mortality. We know that now. That was being presented at ASH. But another question is, knowing what we knew back then, is it wrong to offer that novel therapy to patients? And I don't think necessarily that's the case. I think that there are patients with DLBCL that may benefit from having a different treatment at that point. So questioning that particular point is the debate. And again, questioning why did the investigators enroll the patients in that? I think being accusatory on that, it's problematic. I think it's like write a letter to the editor or call the investigator and say, or try to get information from the trial itself. Any study has a corresponding author. You can request it. Can you give me more information on who were the 10 patients with DLBCL who were enrolled in the trial? I want specifics, histology, K67, IPI, whatever is of your interest to kind of make those conclusions. I think the jumping to conclusions is a problem. You know, that's my opinion.
I think, Liz, the issue that we're debating, and I like how Alan framed it, is obviously, if we're designing it today, we'll have a better design. But the question becomes, what we're debating is, Aaron is saying, enrolling patients with DLBCL run-of-the-mill on this trial is wrong. And what Alan is saying, it's not wrong to enroll. And I think that's where the issue with ethical issues become a problem, right? I mean, if you think something is wrong, as Aaron earlier labeled as possible quote unquote medical error, then we have like a huge thing, obviously. And you can't debate that on social media because, to Alan's point, patients are watching and reading this. So do you think it was wrong to enroll patients with DLBCL?
Well, it's interesting because the more I'm kind of looking at like this table one here and looking at the patients who actually enrolled on the trial, I think that if I could go back and step in that investigator's shoes in 2017, I think there's a lot of them where I could have convinced myself that dose-adjusted EPOC would not have been inappropriate, right? So we agree the 50% double hits, not inappropriate. Primary mediastinal patients, many of them would have gotten dose-adjusted EPOC anyway. And then when you start looking at the breakdown of the rearrangements, many of them had a MIC rearrangement. And certainly I think it's a little more clear now, although there's still debate, people have a MIC rearrangement. It's not as bad as double hit, but I don't think at that time that was as clear. Many of these people, again, had overexpression by immunohistochemistry. So I feel like, let's say I did have all these case files, all 30 patients in front of me, and I could go through. I bet if I went back through and used my brain of 2016, 2017, I could probably feel somewhat comfortable that many of those patients' EPOC would not have been appropriate. I guess the trickier question for me is, when this trial was written, should it truly have been all comers DLBCL? Did we have enough information at the time to, in the inclusion criteria, specify certain subgroups? And that's the part that I guess I feel a little less clear about. And I wonder it's like one of those things where you wonder what it would have been like to be a fly on the wall for these discussions, both not only between the investigators, but, sometimes, when we kind of talked earlier about, criticizing trials and criticizing authors, I sometimes get uncomfortable knowing, like, sometimes I wonder how much control the investigators had, right? If sometimes when these studies are funded by industry, you have to compromise a little bit, and you wonder where there are points the investigator maybe had to compromise and do things they didn't feel super great about because they wanted the study funded and done. So I think that's where I struggle. I bet, looking at the patients who actually enrolled, it probably wouldn't have been completely inappropriate. Yet what I'm not sure about is, should the inclusion criteria have been as broad as it was at the time?
Let me make a counterpoint question then. Aaron, would you be having this discussion if the trial was venetoclax R-CHOP?
No, that would have been fine. I mean, we knew that would have been, we're taking a backbone that is the standard of care, as opposed to a backbone that is more toxic and no more beneficial to DLBCL.
Understood. So your issue here is with EPOC being the backbone, not
EPOC being the backbone, which is a more toxic regimen. And adding a drug, and venetoclax is a big deal drug, so it's scary to add that to anything. It
is. I agree with you. So here's the issue again. We're going back to the same point. Without the caveats of the study, what was being studied was not dose-adjusted EPOC. What was being studied was venetoclax dose-adjusted EPOC. That's a different regimen. The new regimen is a separate regimen. So, you can infer that the toxicity is going to be more, right? That very certainly is going to be more, because then R-CHOP or then EPOC alone, you cannot infer that this regimen is going to be worse. It's going to be the same as EPOC. It's going to be the same as R-CHOP. You can't. The study was evaluating venetoclax EPOC. I mean, it was not evaluating EPOC. It's a different situation.
I know. I think, though, this is where phase 1s gets tricky, and I completely get it. And I think when you're doing phase 1s in, let's say a metastatic pancreatic cancer patient who has failed a lot versus whose therapy has failed them, as opposed to a newly diagnosed, very healthy trial population curable malignancy, I just think my opinion is that I think that the bar for safety benefit, it's different. It's a different story. And
Agreed.
You guys keep on coming up with these little pieces. Well, maybe there was a MIC or, no, they ran the randomized study. Forget about the double hits. There was a good amount of double expressors. As a study as a whole, the best data we had at the time was no benefit. We should not have been using it in any of those patients. People still do.
You feel confident saying there were enough double hits and double expressors to make that assessment?
Liz, I think
but we can't then assume it's better. I mean, we can't this is going back to another thing. I mean,
the same. You didn't have that information, Aaron.
Alan,
certainly for not double hit or double expresses in that study. Sorry, Shadi, I just want to compliment what Aaron was saying. yes, I agree. The bar for safety is different if someone is in the 5th line of therapy,
exactly.
is the 1st line of therapy.
Yeah.
No questions asked here. However, okay, you got to agree with me that we're not doing great by the patients having a 60% cure rate. We want a 100% cure rate. So there's 40% of patients who are underserved by the regimens that we have. The way to make it better is to study those regimens in the 1st line, which is where we have the highest chance for a cure in these patients, right? I mean, if you're going to study, who's going to study venetoclax, EPOC in 3rd line? I mean, these patients they received anthracyclines already. Who's going to receive Ven-R-CHOP in 2nd line?
I'm not asking them not to study. It's just all they had to do in 2017 was switch their inclusion criteria to double hit only. Done.
Well, you still have the diffuse large B-cell lymphoma. That's not cured. I mean, I'm not talking about double hit. I'm talking about DLBCL, run-of-the-mill DLBCL. You have 40% of patients who are either going to have primary refractory disease.
So show it's beneficial in the highest risk population, and then maybe try it in these ones. But
Alan, Alan, what Aaron was saying is, if you were to design, I mean, I think we all agree with you that 60%, we would love for this to be 100%. Yeah. No argument there. I think what Aaron is saying that in the 1st line, you can study the backbone, which is R-CHOP, plus a novel agent. Sure. So R-CHOP plus venetoclax in run-of-the-mill DLBCL, and see if you improve on the 60% and do the phase 1/phase 2. I think the concern is that he brings up, and I have to say that I have similar concerns that in the frontline setting, if you're taking a regimen that you know already more toxic as a backbone than the other one, and it's no more effective, and you add another agent to it, it's extremely unlikely that it's not going to be more toxic. And once you get—
No one is arguing with that.
Well, right. But once you get into more toxicity, then you worry about treatment-related mortality, and especially in the phase 1 setting, where, that's really where the issue is. And I think there were some deaths on the trial in that phase.
There was 1 death on the study. There were more deaths on the Alliance trial, the phase 3 trial, that they suspended afterwards because of this regimen caused more death in the patients. That's what the ASH abstract is showing, which is not something we knew back then. And I want to remind you that the treatment-related mortality on 50303 was the same for R-CHOP and EPOC, was 2.1% in both arms. No difference, okay? It was more toxic in neutropenic fever, but it was not higher mortality rates. Right. So you got to take that in consideration as well. And I understand, and again, hindsight is 2020. We're looking back with our brains from today. You cannot dissociate what you know today from what you knew then, from what you knew, at the time the study was being designed. And I agree. I mean, if I was designing this study today, I would not have included the standard diffuse large B-cell lymphoma.
Why can't studies like this, Alan, Aaron, and Liz, all of you, why can't they be amended? So for example, the trial did not enroll in like 6 months, right? I mean, let's say it started in 2017. And, as we knew more towards the end of 2017, why can't I amend the trial and change the backbone?
It can be amended. I mean, it's burdensome, but it certainly can be amended. I mean, that's partly why the studies have data safety monitoring boards. You have stopping rules, you have DSMBs, you have oversight of the study to understand, is this within what preemptively, as the trial was designed, that what is the agreed upon toxicity rate, neutropenia rate, whatever, death rate, you're designing a phase 1 study. You include those criteria in the phase 1 study. The study continued because in spite of what a different study showed, right, did not show more mortality, showed more toxicity. And, obviously the population is not the same in both studies. I don't know, it was not part of this DSMB. Someone made a decision that this doesn't need to be changed or amended or stopped at that point, which is a different decision than they made on the Alliance trial because they saw excess deaths and they stopped the study, right? I mean, these things are dynamic. And you're looking here and it's, you had more patients, you end up seeing more things with more patients, right? Phase 1, again, highly selected patients who are willing to undergo a phase 1 study in the frontline setting. I mean, there's a number of things here. I'll tell you my experience. I have a phase 1 that, I ran, which was, for patients with high risk hematologic malignancies were undergoing an autologous transplant, that we're consolidating with ipi-nivo after that for 6 months. Okay, so it is a toxic regimen. We understood there was a strong rationale for it. A number of the cohorts didn't work. For lymphoma, it worked great in the phase 1. For myeloma, it worked okay. But, you know, it is something that's more aggressive. We knew about it, but we knew for the diffuse large B-cell lymphomas, for instance, that transplant were working 50% of the time. We want to improve on that. This was study. We had stopping rules. This was evaluated on a weekly basis. That's, you know, those nuances are present in studies. No one's just throwing the study and not, let's just look at the results at the end of the day, right?
So Aaron, you got into some arguments about the study with authors of the trial.
No, I did not comment. I stopped. I stopped once I saw authors were pissed, and I did not respond to any of them. And I never actually specifically call out an author. It was the study. I said I thought there were some ethical concerns, which I still feel and strongly say. You can post this on social media. That is my belief. And anyone I've explained this to, because I ran it by my wife, because I was like, I felt bad. And I ran it by people who were not, and I spelled out everything. So I have looked at the supplement, the people included also. I feel like I feel like everyone has agreed with me. And I've even debated calling those authors, which I plan to, and I'm hoping to run to them to Ash and talk about it in person, because I don't want these people pissed at me. I want people to like me. And if people are angry at me and think I'm bad, I do want to know. I want that feedback, because, you know, it's like, you know, sometimes, you know, it's like a patient thought you were rude. Like, that's important to know, because you want to correct that. And I don't want to come across as that. So I do take this feedback importantly, and I saw some of it. So I am going to reach out to those authors, whether they're receptive or not. I don't know, but I'm going to try. But I still feel strongly that the study was unethical. And again, I'm sorry if that's going to then be a deal breaker in our relationship. Which it might be, that's the case.
So I think that that's a big deal when you say the study is unethical. I want to hear.
It'd be one thing if this was like the first time ever. It's like, you know, there's a gazillion things we do in clinical trials that are unethical, unfortunately, and they continue to happen. So I feel like maybe now we can fix this by being more vocal about it instead of, you know, not. Yeah.
I want to hear from Liz and Alan. Is the accusation that the study is, we're taking away now the science. Liz, do you think it was unethical? And Alan, do you think unethical? Liz, you go first about the unethical component.
I got to tell you, I'm struggling with this a little bit, because like there are people on this author list that, like,
exactly.
This is where it
comes in. I don't think you should put them on the spot. I don't, Shadi. I mean, I don't care. You can bar me from your lymphoma trial forever. I'm happy teaching the medical students and residents. I have my thing. I'm perfectly fine with it. This is where, and I think this is part of the problem. I don't think we can be open as a community because of the implications of being open about things we disagree with in the control. I know this is a fact in myeloma and other things. You can't be. You get kind of blackballed. So I do not want my colleagues who are heavily investigated with their careers to have to comment on this. I don't care. So I'll comment on it. And I'm very comfortable.
So why don't you care? Why don't you care?
Because I love my job. I get to live in San Diego. I teach. I think I have interesting research. I love my clinical responsibilities. And I've accepted the fact that I run clinical trials, but like that, being one of those or being in those groups, I don't have much of an interest in it. And so if they say this guy sucks and he's an idiot and we don't ever want him, it doesn't bother me. They're still inviting me to Ash to write newspaper articles and things like that. So,
Alan, do you think there's some ethical issues with the paper?
No. I mean, and I don't, I'm a lymphoma. I'm not in academia. This is not going to affect my career. If I really thought this was an ethical.
What do you mean? You're as academic as they get. My goodness.
Yeah, you run a bunch of clinical trials.
Are you kidding me?
I'm not in an academic center. That's what.
You're not at the
university. You're pretty academic in my. Yeah, but you can't use that as an excuse.
Yeah,
no, that's fine. But my point here being, thank you for the compliment. I appreciate that. But no, I really don't think it's unethical because, you know, as I said before, I think there are ways to see it. I don't know specifically what was going through the mind of treating physician at that point that led them to believe that this potentially was the best option for that patient. Okay.
Alan, can I ask you a different question then?
Yes.
I just want to see if we can say that anything's unethical. How about and I know you don't treat myeloma, but I'm going to bring up this study. How about the Boston study that enrolled in the United States that had a control arm of fit, you're drinking some whiskey before, that's good, you're gonna need it, that had some fit patients who were getting Velcade Dex, which by far and away, we had numerous times that have shown that that was inferior to many other available things in the United States, randomized to Selinexor or Velcade Dex. Would you call that opening that study and enrolling with unethical?
I would call it wrong. It's a wrong study.
Not unethical, though? You're giving a patient...
What?
Well, what is then ethical?
I don't know. I don't know specifically.
We have to have the strictest standards of ethics in clinical trials.
No. I'm just thinking because I'm not a myeloma doctor. So
I don't think you need to be one.
What line? It was like a fourth line study?
No, you could have seconds, and you could have had Velcade Dex as part of your induction. You can read my letter to Lancet on this.
That's yes, I agree with you. I think that's. But you know, I'm saying this particular one, I don't think
that's fine. That's fine. But my point is that despite all the measures we have, and these are not isolated occurrences, and I think we do need to start. Again, I've made my opinion, and you guys are pointing out some good things. You're making me think, and I think we do need to debate these maybe on social media.
Aaron. I think we do. I think a big, if I can give you any feedback here on that particular discussion on Twitter, I think there's one comment that you made that perhaps resonated very bad with the authors and may have elicited a lot of this perhaps discomfort with it. So, you know, I think
you can direct message me that one so I can see it.
I will direct message you. But I
thought I took it down, or
I didn't direct message. We're on the podcast. Which one was that? This is a podcast.
Yeah, you can read it. Listen,
I know. I won't put Aaron in a bad spot.
No, you can read it. I did it. So, like, again, I'm trying to make friends with them. I don't want people hating me.
So did you ever? I'm just curious.
Your comment was
no. Let Liz talk.
I just have a question. Do you? So I didn't see this whole exchange. So maybe this is good, maybe this is bad. But like, you have to. I'm starting to wonder. Like, we're having this conversation now, and like I was looking at like when. Okay, so people were asking when the study enrolls. So February 2017 to June 2019. For what it's worth, 50303 wasn't published until July of 2019. Whatever, take that with a grain of salt.
The abstract with the PFS.
Sure. Yeah. But whatever. But you know, you have to wonder. I'm wondering if some of this discussion, like again, we weren't in the room when people had this discussion about the study. We weren't in the room with the conversations with the industry sponsor. We weren't in the room for any of this. And so I do, you know, you have to wonder if maybe some of the criticisms you're pointing out, maybe the authors themselves were fully aware of, and maybe you're just kind of striking a chord with questions they've already asked and wrestled with.
It's possible. So I agree, it's possible. And you know, to the point of the abstract, Aaron, you cannot say a 400-word abstract that's on ASH is sufficient to inform enough as it would be a full manuscript.
It was sufficient to stop a more toxic regimen. I think it was. That's my opinion.
That's a debate.
So you disagree, so you kept on giving it. It's okay. I was enough for me.
That's a debate. But let's go back to your comment, Dan, because I'm sure people are curious now.
I mean, I stopped the second I saw that. I stopped.
You said, how can you look someone in the eye with non-double hit DLBCL and consent them for the study and feel good about it? So I think that comment, I think that comment goes straight to the investigators who consented the patients to the study. And my point here is that, you know, it is a loaded comment, Aaron. It's a loaded comment. You are going straight to the core of what it is being a physician, right? Being a physician is trying to do what's best for your patient. It's trying to give them the best outcome with the most safety and whatever suits their life and their choices, right? So when you're saying something like this, you're telling a physician that how come they did this? This is like egregious that, you know, how come you offer this trial? This is like horrible. How do you feel good about it? That is a very loaded comment, Aaron. And you know, I think that if I were a patient following your Twitter feed, and you have a number of them, I'd be like questioning a lot of things that, it's an accusation. It is an accusation. It is. I'm sorry. It is veiled, perhaps not your intent even, but it is a loaded accusation to the investigators that they're unethical. And if I was on the other side, if I was an author on the study, I'll be really upset. You know, I would personally upset. It would rock my own beliefs of what's being a good physician and a decent physician. I think we need to establish a baseline of that, you know, our colleagues are at least honest and have integrity, and they may have had reasons to do the study or not. That's my point. You know, if I can give any feedback, and I think that's possibly what struck wrong with a number of these physicians.
Aaron, any comments on that?
Yeah, no, that you know, I'm not going to make an excuse. It was a bad tweet, and I apologize. And I will talk to the investigators. I agree with you completely on that. Okay.
Thank you. I think that's all. I think everything else that you commented was completely fair. I think that that one is like
but because I completely agree with you. All I can say is what I should have said I can't look someone in the eye. You know, as you did that consent, which I thought was good for the study, I still feel that I don't see how someone would agree to that study. And again,
that's fine.
My tweet, that was, you know, the classic to get around, you know, and that was, you know, I don't know what I was thinking when I did that. Bad thought. We all make bad decisions. So
we make
I
bad
apologize.
Decisions.
But
and the thing is, the filter has no filter. We have all like perhaps started typing something because we were upset or whatever, and just kind of comes out.
I think the conclusion for me is we need to get Liz more on social media. I think, Liz, where were you when all of this was happening?
She's there. But
was it the last 2 weeks? If so, I was on service. That's my excuse.
Liz, I was on service last week. I managed to still fire off a few tweets, you know.
Well, you're just better at using your time than I am, sir.
Look, I think this is great. We've talked about real world evidence in clinical trials. We've talked about the difficulty of really criticizing clinical trials on social media. We use this trial as an example, but I want to try to kind of level set and have a path forward. And you know, in the next few minutes, maybe I want to try to see what's next. So, Aaron, I mean, what is next? Like, how are you calling for clinical? Do you feel we need a clinical trial reform? Do you feel there are issues? Like, I don't know, like I'm trying to figure out, let me tell you why I'm asking this. I'm asking this because I think we can all agree there are no perfect clinical trials, right? I mean, I would, in fact, if you ever submit a paper and you don't have limitations at the end of the paper in the discussion or the shortcomings of whatever you're publishing, the reviewers will send back and they will say, well, talk about the limitations. There are limitations to everything. So in the absence of perfect studies, what's the path forward?
Well, you know, I can't, you know, as I always say, like, you know, and when I get you know, people ask me, what's your thoughts on, you know, reforming Medicare and all these things? You know, I can't fix everything. That's not, I can do what I can do, but what I can do and what I think is successful is I do think in a not the way that my one tweet that Alan pointed out, that was not the way to do it, but there is a way to bring up these issues on social media and make people think about them, especially those in training and in the newer oncologists. And I had a young assistant professor message me saying, I agree completely with you, but like, how, you know, what are you going to do? You're not changing anything. And that's where I disagree. You know, Karyopharm, I applaud them, even though I hate their drug. I don't hate their drug. I don't think their drug's helpful. They recently changed the control arm from Pomdex to Elo-Pomdex in their randomized study, which was great. That's a great study now. It's like it's going to answer a question. I know that a study that I was critical of and pointed out to people that was using a very toxic drug in smoldering myeloma, asymptomatic patients, giving them a serious drug that should not be studied in the smoldering setting, has been closed, partially due to some things that I brought up. So I think, you know, that's what I can do. And, you know, my hope is that the trialists, those writing it, which is not me, that's not my role, with the increased awareness and maybe a little bit of scrutiny, start taking these things into account. Now, that's what I can do. Maybe the other investigators have solutions from the, writing the trial standpoint. Obviously, yeah, make it easier to make changes. But that's easier said than done. I don't know how to do that. Or fix the problem with, pharmaceuticals have their motives. Their motive is to, they want to help people, but they want to sell more of their drugs. So, even these big cooperative groups, a lot of their money comes still from them. So you got to please them. You have to make these compromises. I don't know how to fix that. That's a huge problem.
Liz?
I think a lot of it does. There's a lot that needs to be fixed, right? And I think that I agree with Aaron that unfortunately dollars carry a lot of weight. And, as I mentioned earlier, I think there's a lot of things we've all compromised on when writing trials because the sponsor, whoever that may be, wanted it done a certain way. And at the end of the day, you want your trial, you want your patients to get drugs, whatever. And sometimes you end up compromising. And so I do think there is some, going back to some of the real world evidence stuff we talked about earlier, I do think there's a push to make clinical trial populations mirror the real world a little bit more. Look, it's not perfect and it's not going to be perfect. Like I was part of a NCI discussion about how to get older patients better engaged and enrolled in clinical trials and how do we make clinical trials more friendly for older patients. There's many populations where we should be sitting down and talking about these things. But I think the hard part at the end of the day is where the money is coming from. And it would be nice for there to be just pots of money where we could use whatever drug we wanted and no one had to weigh in. I'm sure there would be some sort of fallout of that too. So I'm not entirely sure that I have an immediate solution other than all of us who are writing these trials can advocate the best we can, be cognizant the best we can. One that I'm involved in right now, or just now, we know that my older patients at DLBCL, multiple people have told me, what are you going to do when POLARIX comes out? So we're trying to think about that now. There's going to be data that's going to possibly change how we do things. So I think what I can do is make my studies good and be responsive to data and just kind of hope other people do the same.
Alan?
I think that's a lot. Do you have another hour for another podcast on this? I think that's a very
we should have one
very long
reforming clinical trials.
Very long conversation. I think one. I agree with Liz's comment. I think there are competing interests in all that we do, right? In research. Independent of what the side things are. It's a pharma or something criticizing pharma or reviewing. There's always a competing interest one way or another. They may be financial, they may be non-financial. Lots of times the strongest one is the financial one. But, I think that efforts to minimize those competing interests and conflicts of interest are important in any kind of research. I think that particularly pharma companies should incorporate patient advocates when designing a trial. There are patient advocacy groups that are very knowledgeable, very strong. I don't know if any if Liz or Aaron went to the Vail Cancer Camp, ASCO, AACR. They had, you did, right? So I did too. They had a patient advocate in the room, at least in my group, helping us with our trial designs. And that was tremendously helpful. Did you have that too, Liz?
We did. And also that is something that I can't speak for every working group of every intergroup, but at least from my experience on the lymphoma committee on SWOG, we have an amazing patient advocate who brings so much to the table.
Yeah, they bring too much to the table, which is in the intergroups, they have it, but I don't think necessarily pharma companies have that in their docket when they're designing trials, the trials that are, pharma initiated and come to us. And I think that should be important to have, right? So that's one aspect. I think that there should be an effort to include underserved populations. I'll applaud Roche and Genentech, for instance. We ran a trial for COVID with TOSI, and the trial specifically enrolled Hispanics and African Americans in the study. It was designed for that. And we had a separate trial that was all comers, but we have one trial that, really the majority of patients need to be from one of those populations. which, so, there are efforts that are starting to come into play to incorporate more real world populations, more diverse populations in clinical trials that will be more informative to all of us. I think that watchdogs are necessary to keep people in check. I think the watchdogs need to be watched as well, because lots of times they end up having conflicts of interest too, because sometimes careers are made out of being a watchdog. Different debate here, but I think everyone is to just do better. I don't have an answer. I really don't.
Shadi, I have one more answer.
Yeah,
because I do it and I think it's easy, actually. I see a lot of complaints on social media about trial inclusion, like, why did they exclude HIV for no reason? Happens all the time, the clinical trial. So I've made it a practice, the few studies that get offered me, if a clinical study gets sent to me and they exclude HIV for really no legitimate reason, sometimes there might be, I just say no, no, thank you. The problem is it's moot, because everyone else is still going to say yes, and the study will be done. But if us as investigators all truly walk the talk, did what we believe that we really should do, that we would just all say no to these studies, but we don't. So, but
I do.
Some answers, what?
I do too.
I do.
But the studies still get done.
To that
The
point,
sponsors can't do the studies without investigators agreeing to do
Aaron,
it.
I'll tell you what, that's a pet peeve. I'm going to tell Aaron that's a pet peeve of mine too. And I will also tell you I was successful in getting somebody who removed that from exclusion criteria.
Well, that's awesome. We need more Liz Brems.
There you go. And I think, that hits an important point, Aaron. I think that, and again, I'm not in an academic center, so I have no horse in this fight, or no dog in this fight, that that's just because it doesn't affect me. But I think promotion ranks for academia should start removing number of publications from criteria for promotion, because that does elicit that publish or perish kind of.
Yeah, it's financial for the investigator.
No, of course, yes,
exactly.
It does elicit a publish or perish paranoia, and people may end up accepting studies that otherwise they may say no to, and and that's one thing. And the second thing is that we need to be more nimble in changing studies as new data come along, even if the study is already ongoing. And there's the sunk cost bias in clinical trials, right? A lot of times pharma puts so much money already in the study, and something comes along to disprove the theory, and they're like, well, we're already bought in, we need to finish it. That sunk cost bias needs to be removed, and say, hey, data came along, let's just stop it. Right. And so these are the reforms that need to happen. It's an uphill battle. It's a tremendous one. But
I have to say, this has been really a lot of fun. We are right now, this is just so you know, I mean, in terms of when we are thinking of airing this is, around December 21st. We'll probably do it December 14 to make it closer to ASH, actually. Which would be like the last day of ASH, because this would be actually great. But this is a lot of fun, and actually really valuable in terms of everything that we talked about. I personally find having these conversations in a longer format, like a podcast or a webinar or something, way more valuable for the debaters as well as listeners than really a Twitter thread or like a 240 or 280 characters. I don't know about you, but I feel strongly that the only way to rehash things is to give opportunities to talk about them in a longer format.
Yes, but if it weren't for the Twitter thread, we would not be having this discussion.
I like that. So basically, we are going to air this actually December 14. We'll do this December 14, the last day of ASH. Was I supposed to ask you all anything that I totally forgot or overlooked before we part ways and see each other at ASH? Hopefully.
No.
What time are we having a beer together at Ash? I think that's the question.
Yes,
any day. I'm there for all 5. I blocked off my clinic, so
I'm there the 10th, and I depart the 14th, and then I'm gonna have like a bag full of T-shirts. Aaron Goodman, Papa.
Oh, I want 100 of them. I like the women ones better. I'm not gonna lie. I wore my wife's by accident. I was like, I like this.
I don't think those will fit me. I still want the extra large.
Liz, if I see you at Ash, I'll give you one there. Otherwise, please send me your address. Look, Liz Brem, Alan Skarbnik, and Papa, Aaron Goodman, thank you so much for coming on Healthcare Unfiltered. I'm going to keep calling on you because I love having you on. Thank you so much.
This was really fun. Thanks for having us.
And the star of the show is Aaron's daughter.
Where's the baby?
So I don't know if you heard, she cried. So it's just me and the baby right now. So she cried a little bit, and then I did the move. For any parents out there, they know that it's called My Baby Bum. Okay, it's this YouTube thing.
We
it's
haven't tried this one
it's like
yet.
crack for kids. It never fails. They calm down, and it allowed us to have this podcast. So I want to thank My Baby Bum. It has 10 billion views on YouTube.
Oh my God!
My Baby Bum. BABYB1.
And for
those of you, it works every time.
For those of you listening or watching on YouTube, now you've got a free tip. Thank you so much.
Thank you.